Good afternoon, ladies and gentlemen, and welcome to our today's webinar about spine endoscopy. Under the headline Endoscopic Precision, we offer a lot of webinars and we share the experience of experienced users together with you. And together with you, we would like to discuss all that topics together. Today, we are very happy to are connected to Dr. Scott Adelmann in Utah, and he will talk about the topic adapting to unique challenges for L5-S1, discectomy and decompression. So we are all very happy and proud that we could share this experience today with Dr. Scott Adelmann. And I would like to switch over to Utah now and want to welcome Dr. Scott Adelmann. Hello, can you hear us?
Yes, thank you very much, Dirk. How am I coming across okay for you folks?
Thank you. Yeah, thank you very much. Yeah, we did some webinars already, and we were very happy to share this experience with you because you are doing a lot of cases, and since a very long time. Could you let us know how long you are doing endoscopic spine already and now in the US?
Yes, again, Dirk and Rero Spine and all of the folks, thanks again for having a chance to come back and share some stories. My journey began a little more than 20 years ago, about 23 years ago, and I was introduced to the Rero Spine endoscopic community working with Tony Young, the now retired Tony Young, and he was a great mentor. And then over time, I was introduced to both Martin Komp and Sebastian Rutten in your backyard, and they've been a significant influence on my career for several decades. And my work now is pretty much focused on endoscopic work on a weekly basis, again, with a couple of decades of experience and a few thousand cases. And my average caseload now is about 4 to 8 cases a week, and I'm really focused on developing a platform where I can share those experiences and participate in your educational programs, and most importantly, working with colleagues that are really serious about taking on the challenges and the implementation of endoscopic spine surgery. So thank you for that honor, and I appreciate being here today.
Thank you very much. So then I would recommend to start right now with the lecture about adapting to unique challenges for L5-S1 discectomies and decompression, together with Dr. Scott Adelmann from Utah. Please.
Well, thanks again and welcome to everybody all over the world. I hope everyone stays safe and you're doing well in these challenging times. We in Utah are making some progress finally. In the realm of endoscopic procedures, and in my experience helping out with training and teaching and proctoring and such, L5-S1 is always the hot topic and is always the focus of challenge with almost all the practitioners that are trying to adopt endoscopic surgery as part of their practice. And some of the comments I would share just to start off with are my observations over now, 20 plus years, looking at the progression and implementation of endoscopic spine surgery and challenges associated with indications and targeting. And I would share that it's a very evasive and evolving approach. And that's what I see most in folks that are trying to adopt and adapt the challenges for endoscopic surgery. But I will share that, and my teachers, especially, I've been honored and pleased to watch their progression and the advances that are taking place, and then I try to incorporate that into my own work. So let's talk about and begin this journey on the L5-S1 frequently asked and frequently focused upon challenge. And today's presentation and our discussion, which I hope to share with folks, is just the beginning of a journey, and we certainly already expect to do some additional work, especially at the L5-S1 level, that will support as well as perform some of the excellent standards, if you will, and direction that I actually get from Rero Spine and their experts. So moving on an L5-S1 approach, the first thing we have to decide is, can we even do a transforaminal approach at L5-S1? Or is it always going to be a central decompression? I'm going to share a couple of cases with some quick slides on targeting, needle placement, and how you can look at the foraminal approach at L5-S1 without getting stuck on doing any particular work that is not directly visualized. So here's a case and an example of a patient who, and I'll give you some quick background. It's a male patient whose MRI wasn't that impressive. And in this instance, they ended up with a single level discogram and a CT scan. And I'll show you the coronal view. And if you can appreciate, there's a very small left paracentral subarticular recess displacement on the coronal. And if we go to the axial, you can see there it is, very small, contained, and displacing or at least touching the S1 nerve root. And I'll have to share with you, the short answer is it was very consistent with the patient's presentation, very consistent with his response, and then failure to have a significant improvement with conservative care, including injections, et cetera. So in this case, my associate asked, which direction and which approach would you choose? And if I'm trying to be as quick as possible in my hands and do as little tissue disruption, I'm going to do a transforaminal. But you'll look at that picture and say, that's going to be pretty difficult to get in a subarticular recess with that particular approach at L5-S1. In my experience, yes, it is very challenging, but I also would choose to try it. I want it to be my first attempt. If I fail, I might have to convert to a midline interlaminar, but I'm going to save that example and those discussions for the future. We already have things to discuss regarding that, but let's just focus today on the L5-S1 transforaminal approach. So if you look at the patient, they're on the table, AP view, left being left, right being right. My initial target's going to be the middle of the L5-S1 disc. What's missing in this particular slide, though, is I would do a little bit of a Ferguson view where I can get that S1 end plate to line up better than it is here. I don't have that picture, and I apologize to share today, but I wanted to give you that point. It's an important point that we'll get back to with future discussion. I'll pull that line on the patient, and it looks like so. And then I'll take my pointer, and I will actually create a line that is from the target center of the disc up over the iliac crest. And it looks like that on the fluoro. This is going to be the trajectory that you'll have to utilize to try to get over the iliac crest and get to your target. At that point, I'll take this work and I'll look at the distance from that lateral mass of the facet to my skin incision, and I'll simply take that distance on the needle and advance a needle into place that quickly. Not going too close to the spine, not getting in trouble yet, just getting my trajectory. Now in the AP view, you and I can't tell if that's a good approach yet. So we've got to convert that to a lateral. Now here's the lateral view of the exact same approach. What would we look at to be critical of this at this point? Well, the good news is it's on plane with the top of S1, which is my target and very appropriate approach. It's still not in the foramen, not too anterior. And what I'll share with you is I could actually feel that it was touching the lateral mass of the facet. So I know I'm in a very good spot. From here, you will practice and develop the skills, especially in our labs that we like to support, of just simply walking that needle off the superior articular process and entering the annulus very carefully. And you'll progress that in a lateral. In the beginning, if you need to check your AP views, you should. But I'll just advance this for the sake of today's discussion and show you that's what it looks like when you get to the annulus. At that point, for teaching purposes on this particular case, I'll put contrast in the disc, I'll put a little antibiotic in the disc for infection management, and I'll also try to color that disc with the various staining agents that may or may not be available in your markets. Here's the AP view. That is an interpedicular line just at the edge of the annulus, a good place to be to do a discogram. Simple. That's what it looks like when you infiltrate. And again, this was not necessarily for diagnostics, but it was for tissue staining. And if you look critically at this one image, there is a little slight extravasation of contrast right at that targeted herniation on the discogram and CT scan at the very beginning. Here's just simply a lateral view. I won't dwell on this. This now is the placement of the dilator down over the guide wire, and the tip is in the inferior foramen. And if you look critically or closely at this, you actually can see that the L5 contrast comes down and actually drapes over the tip of this dilator and is exiting down to the sciatic nerve. Once you've placed a sleeve, and again, assuming that you've seen some endoscopy work in the past, you know that you put the sleeve over the dilator, pull that out. Here's the very first picture. And it's important with this approach at L5-S1 and transforaminally that you immediately identify your targets and your tissues. So here's the first picture, still confusing, can't quite tell or distinguish between disc, some capillaries, maybe even a lateral aspect of the exiting L5 nerve. So with your tip control and radiofrequency bipolar, you'll learn how to clean this up and make it look like that. Little fuzzy picture, I apologize, but most of that is disc and disc herniation. To the 9 o'clock position is a little element of something a little pink and may or may not represent the lateral edge of the L5 nerve. So you've got to be very careful at this point. Working with your micro rongeurs and your instruments to extract fragments. Here's taking some of that, doing the discectomy and decompression, and your goal is to do this carefully until you can identify your structures and your tissues clearly and have it look like that. So in this particular picture, you've got annular fibers in the center, some transiting structures at the top, exiting L5 at the left. And if we hold that spot with an instrument, we can then actually use the working sleeve as a retractor and elegantly take a look at the foramen. So there's the tip control, holding my decompression spot, and I've rotated and retrieved or retracted the sleeve just to let that L5 nerve drop into that space. This is the picture of how much work you can get done at transforaminally where you're just trying to remove target. This particular case was a subarticular decompression. It was contained, and that actually was a successful procedure with this patient who followed up subsequently with resolution of his left leg pain. So let's transition to one more example before we get to hopefully some good discussion. And this next patient has a similar left L5-S1 targeted pathology, but if you notice and look at the image quickly, that's actually a complex loculated lobulated facet cyst right in the foramen, essentially occupying the entire L5-S1 foramen. Axial view, sagittal view. Again, if you can appreciate the lowest foraminal segment, that's all cyst. Difficult in that one slice to even see any nerve. So approaching this from an identical fashion where we target the center of the disc on the AP, we look at that line that incorporates just passing over the top of the iliac crest, and we approach this lateral view in the disc, AP view just inside the disc, and again, I used, for teaching purposes, some coloring contrast agent here, which you'll see clearly in this one. Here's the foraminal view, the very first thing, and again, I'll stress it's important to identify the structures before you start to do too much work, but this is a complex view of cystic structures, some capillaries, and again, not sure if that's that left L5 nerve right there at 9 o'clock. Once you've had a chance to use your instruments and tip control to gently identify these tissues, now you're clearly looking at the blue stained annulus and disc, some epineural fat at 9 o'clock where the L5 nerve will be positioned. And again, if we hold that spot and we rotate and look, there's a complex cyst that's been ruptured. That's some of the tissue. And L5 is just sitting right at 9 o'clock. So from here, we spend the time, we clean this up. This is a very quick transforaminal surgery. This patient, the procedure itself was minutes, just several minutes. Here's the completion. You can see disc, you can see foramen. That's the axilla of the exiting L5 nerve that in dynamic visualization is pulsing and free and clear. At the end of this, I may do a simple injection of some medication, so I'll put a guide wire in place to hold that. And then as I retract the working sleeve yet again, you can clearly see that's the L5 nerve dropping right down. And again, dynamically, that's free, clear, and pulsatile. I'll put a few medications in there just to make it feel good post-op. And that's the end of the case. Let's open it up to some conversation at this point, and I really encourage folks to feel free to ask questions. And also, I'm going to be very interested in your direction for what's next when we get to more advanced cases. We have a lot of these. We'll be videoing and filming 3 cases Friday as part of a training lab. So I look forward to sharing more of the intricacies when it comes to adapting and adopting the L5-S1 approach. And today, of course, has only been transforaminal, but we will be prepared to share the dilemma when transforaminal isn't good enough or can't actually solve the problems you're encountering at L5-S1.
Thank you very much for this nice presentation. Very interesting cases and, of course, very difficult cases, especially if you want to start with a transforaminal approach on L5-S1. These are the most challenging cases. I mean, just to see how far medial or intraforaminal you went, could you show this case or 2 cases on a bone model, probably for our guests here again, because that's but this probably also describes a little bit more the situation and the narrow situation that we see there, and also the difficulty that you can face when you are there, right?
Yes, and I hope for the listeners that are available or those that check in at a later time, I hear a lot from my colleagues and those that are participating in our labs of the various specific challenges, whether there's stenosis, do you have a stable grade 1 listhesis, do you have compression from scar, osteophyte, et cetera. So it's very complicated, but one of the things I've shared in previous talks and one that I've given on behalf of our work all over the world was a case where a patient had some recurrent issues and disc issues that required me to go back months and years later. And I was able to take a picture when it comes specifically to where you can be of a transforaminal approach where once I've placed that needle and I've made it past Camden's triangle and the exiting nerve, and that needle is actually in the spine, the tip of that needle is further into the subarticular zone than we ever used to think. And I will share this in our future presentations, but I put a working sleeve in the transforaminal approach on this specific patient. And then I was actually forced to do an interlaminar procedure because of an extruded central disc. And I took a picture showing, believe it or not, that you can see in an interlaminar approach, you can actually see the transforaminal sleeve sitting in the correct spot.
Yeah, okay, yeah. And can you rotate a little bit more to the left side? I guess it's...
And we may have some technical difficulties. I am talking with Dirk, but I might have lost you.
Yeah. Could you please rotate the model a little bit to the left side? I mean, you cannot hear us. Sorry. Can you hear it? Can you hear me? Can you hear me now?
That's live.
Hello, that's live always. I can hear you, Dr. Adelmann. Can you hear me? Can you? I hear you. Okay. We cannot communicate. Okay, then we try to solve this technical problem right now. Can you hear me now again? Sorry, ladies and gentlemen, but that's live. Sometimes it happens. The internet connection is not always the best one everywhere in the world. And then we try to come back now. Sorry for that. My colleagues try to solve this problem right now. Okay. Yeah.
I'm back.
Yeah, now he's back. Sorry. Ladies and gentlemen, sorry for that disturbance. Sometimes technical topics can be challenging, but now I guess he's back. Can you hear us now?
Yes, I can. I'm
Oh,
not sure.
very good,
I'm
very
not
good.
sure which side of the ocean we can blame that on. I apologize.
No, I'm fine. No, I just ask you to rotate the model a little bit to show the foramen in a better way, that we see the placement of the needle. And can you explain where the disc herniation was exactly located in this first case? Because
yes,
yeah.
and my quick question. I apologize to the participants if I for the technical difficulty. But is my video showing up on your end?
Yes.
Yeah.
Yeah.
Okay, good. Because mine is not, but I'm okay because I can work through this. Thank you.
Yeah.
Yeah. So in this particular model, as you look at this, the herniation on this patient was a left L5S1. Mm-hmm. It had a foraminal component, but it had a central extrusion below the level of the disc. So the dilemma with adopting and adapting the approach is, well, if I only do midline, am I going to get the foraminal component? Because it was significant. But if I do the foraminal approach, am I going to get the central component? So this is a conversation about rather advanced adoption of both techniques in one particular approach.
Yeah.
And we'll have a future video that'll show the exact case for the next presentations. But in this instance, I needed both because that herniation was not going to easily be removed from just the single approach.
Yeah.
And thus, I will share again, and I'll have these things for your viewers. In the future, I want to show you a picture of just how significant the access can be from a transforaminal approach.
Yeah.
When historically we've always said you can't get there.
Yeah. Okay. And how often do you have to resect bone at this point there? Because
well, and again, recognizing that there's conversations that have been going on for many years about whether you do or whether you don't. In our series that's coming up, I'm going to give you specific techniques on how you can cannulate the L5S1, and I've never had to remove bone to get there before I begin my work. Mm-hmm. Now, I frequently remove bone, especially with your elegant articulating tip burrs. I don't do any bone resection until I have direct visualization and tissue identification.
Mm-hmm. Okay. Are you using the 7mm working sleeve or the 8mm system for that?
I'll incorporate both. Sometimes the approach, I want to be as small as possible, so I'll always go small. But selfishly, when I really want to do some elegant bone work and I want articulating, of course, I'm going to choose the appropriate setup and the appropriate instruments that allow me to use the articulating burr.
Yeah. Yeah. So you can do everything under direct visualization. I think that's a very elegant tool, and now it's also available as a diamond burr, so it's even more safe. And if you do that with such kind of,
I couldn't stress that enough, and I would repeat that, Dirk. I think one of the things that I've been most appreciative of over the years is the development of ReWo the articulating diamond tip burr. It is not only elegant and really precise, but when I first started, I underappreciated how safe the diamond was. I didn't recognize that until I really started doing some advanced and really recurrent scar tissue work, severe stenosis problems, when you're up against essentially, a rock and a nerve.
Yeah, and you have pretty got good feeling when you deflect the tip that you feel that how to press to the bone and how to resect the bone there, right? Yeah,
Exactly.
Of course, I can imagine at these cases, it is quite useful to have this because you don't have a space to move the whole cannula there with the drill inside. So this could be always a problem, especially when you're close to the exiting nerve. Then probably you could press the exiting nerve, and this is how to avoid this with such kind of deflectable instruments, right? And
Exactly.
and of course, this first case was like this, even mediolateral part of a herniation of a disc, that was, and you could reach that. How often do you have cases with pure extraforaminal disc herniation at L5 as well?
Well, in my particular practice, I see probably, a good 15 to 20% of my cases are foraminal, extraforaminal, and that grows. Of course, it ebbs and flows, but it's a significant part of the practice. I see a lot of far lateral, and in my community, my colleagues that I work with intimately over many, many years are starting to recognize that superior aspect of a foraminal far lateral approach with an endoscopic technique, and they've really come to recognize that in our circle.
Thank you very much. Yeah, very nice presentation. And to all participants who are watching us today, if you have any questions, please let us know. Please send a message to the YouTube chat function, or afterwards, please send us a message to education@rivospine.com. We will answer all your questions. Would like to discuss with you that we would like to, if you are interested in trainings, we offer a huge educational program, and we are just in front of another workshop together with you in Utah on this weekend, and always booked, fully booked, this workshop with live presentations, with good cadaver labs there, a very intensive course for participants who wants to learn that and who wants to improve their endoscopic skills. And that's I could highly recommend. Whenever you want to learn something, please join one of our courses. We will help you to support you during your start in spine endoscopy, and we are very happy to do that with Scott Adelmann in the US this weekend in Utah. Yeah, I hope very, very soon that I can come over very soon and can join one lab in the US, and hope to overcome this pandemic very soon, and that we all can come together and do our educational program together. So far, I don't see a question. Yes, I see a question right now. There is a question from Ho Van Hai. Is it possible for you to burr around with diamond burr when you approach by transforaminal way? I mean, if
Yes,
yeah.
Go ahead.
Yeah, I mean, that's probably the question regarding a deflectable burr, because I think it's only possible if you use a deflectable burr where you can deflect the tip, or isn't it?
Yes, and I think that's an excellent question, and again, to share with all the viewers and listeners both now and in the future. That is one of the most important L5S1 questions that we frequently see and try to teach and direct. In my experience and in my opinion and my recommendations, this is where you need to appreciate the direct approach to the foramen. You need to understand the different working sleeves that RivoSpine provides, because you're always trying to protect the exiting nerve. Once you can identify the tissues, indeed, that's exactly where the diamond tip is most efficient and highly regarded. That specific question from your physician is very important. You can directly visualize your target. You can remove soft tissue with biopsy forceps instruments, and then bony anatomy where you need to decompress. That's where the elegant, articulating, high-speed diamond burr, it really shines. And I'll stress, it does come in different sizes too. So you can actually be very clever with your working sleeves, as well as very specific in choosing the diameter of the diamond ball itself. And we're really very pleased to be able to teach and train folks on how to adopt that. It's really an important philosophy. And Dirk, I see you have some great instruments to demonstrate, so please share.
Yeah, here in the meantime, I got one deflectable burr, so I can just demonstrate that. I mean, the huge advantage of this deflectable burr is that we can adapt here a diamond, either a diamond or a regular carbide burr on the tip. Here, unfortunately, it's not here inside, but then you can deflect the tip and you can really control the pressure to the bone with your thumb here. We connect that to the motor handpiece, and then we can work around the corner without moving the endoscope that much. And that's the huge advantage, especially for the transforaminal approach, and especially at L5S1, because there's not much space there. And so if you just bend here, so you can work around the corner with your diamond burr. And since last year now, we can even offer a diamond burr for using that, so it's less dangerous if we do this. Yeah, that was a very nice question. Thank you very much. To all participants, if you have more questions, please let us know. We can directly discuss with Dr. Adelmann today. So I don't see any more questions, but anyway, if you have questions, please let us know. You can send us your questions to education@revospine.com, to our website, or you're going to our website. There's a contact formula where you can fill out and send it to us. Whenever you have questions regarding our educational program, if you want to incorporate these endoscopic spine techniques in your daily practice, then please contact us. We offer a huge educational program for basic techniques, lumbar techniques, decompression techniques, cervical techniques, everywhere in the world. So wherever you see us right now, we offer that in the same quality in many regions of the world. So please do not hesitate to contact us, and we will send you all the dates for our educational program. So thank you very much for today, for joining our webinar. We will inform you soon about the upcoming webinars. Of course, every month we offer many webinars in spine techniques, endoscopic spine techniques. And you will hear a lot of different things, not only lumbar applications, but also cervical applications, and decompression techniques, bony decompression techniques in cases of spinal canal stenosis. So just get in contact with us, and we will help you wherever we can. We are back now with Dr. Scott Adelmann, so we don't have any more question left. Yeah, thank you very much. I say thank you very much. Looking forward to our next webinar. Very nice cases. Always good to discuss those cases with experienced users, to share that experience. Thank you very much to you.
Dirk, thank you very much. It's really a pleasure. And as important as anything, I hope folks feel confident and are motivated to actually share some future questions for our efforts and my efforts. Your questions will dictate where we go and what we share next. It's a long journey. We have a lot more to share, and I wish everybody the best. Be well, stay safe, and we look forward to getting together very soon.
Thank you very much. So the webinar stays on YouTube, available whenever you want to see it again. You just have to join the RivoSpine YouTube channel, and you can recall the webinar and upload the movie. Thank you very much. Hope to see you soon. Thank you. Bye-bye.